Hi everyone, this is Ben Landgraf. I am going over topics that were commonly missed on the Anesthesia Knowledge Test that the CA1s took back in August, at the end of August, really. I do reviews like this every so often after every big test. The testing services will send out a list of topics that were commonly missed, and I like to review those topics so that you all can close those knowledge gaps and do better on future exams. Um, in this particular presentation, each topic here was missed by at least half of the CA1 test takers. And so they're definitely good topics to go over, and topics that many of them are topics that you'll certainly see again on future exams. Just another sort of public service announcement is that, in now the beginning of October, fall moving on into winter, now is definitely a key time to really create a good study plan for yourself that balances the clinical demands as well as the academic demands. We will have the ITE in February. I like everybody to prepare as well as they possibly can for that exam, because there's a great correlation between performance on that test and how you tend to do on the board exams. It's especially important for the CA1s here because the basic exam is given at the beginning of June, and of course, your whole year is sort of used to prepare for that test and to be successful. Last year, I was very happy with the residency as a whole on the ITE. A lot of people got greater than the 90th percentile. Our CA1s had a 100% success on the basic exam in June, and so I know that you all can do the exact same, but it will take a lot of work, a lot of planning, but I know you guys can do it. So if you need help forming a study plan, please come see me early rather than late. You can also talk with your mentors. You can ask me to help you speak with somebody if you're more comfortable with somebody in the department. But really, try and do your best to create a good plan and do well on these tests. All right, so here we go. All right, our first topic here is the difficult intubation assessment. On some of these slides, I've also included links to nice little short articles to read about the topic, which will help to solidify the teaching points that are within every topic here. So when we assess for a difficult intubation, there are many different ways that we can go about doing this. Each of these ways has their own varying sensitivities and specificities. And we also have to be mindful of the fact that difficult intubation is different from difficult ventilation, and there are different risk factors that would lead you to believe that one of these things may be the case. So when we see a patient, we should ask, does this patient have any sort of breathing difficulty? Do they have sleep apnea? Is there a person with a big bushy beard that's going to cause trouble forming a seal? Is the patient obese? Does the patient have history of either a difficult intubation in the past or difficulty ventilating? Sometimes anesthesiologists will write notes in the chart if they've had a particular amount of trouble. Then there are different exams that we can go through to assess for difficult intubation and difficult ventilation. A dental exam is very important. If patients either have no teeth or many missing teeth, that can cause more trouble ventilating. It often is easier to intubate patients because we don't have to worry about the space that they take up or potentially knocking teeth out, but ventilating is often more difficult in this setting. We should assess for mouth opening. If a patient is able to open their mouth wider, that gives us more space to operate. Of course, the Mallampati exam is important, stages classes 1 through 4. Thyromental distance is important. That's the amount of space between the thyroid cartilage and the front of the chin. And what that represents is the amount of space that you have to displace soft tissue and the tongue anteriorly when you're intubating. TMJ mobility is important to assess. So if a patient is able to bite their upper lip, that leads you to believe that they can protrude their jaw forward adequately, which gives you more work room. And then neck mobility. If a patient is particularly stiff, if they have comorbidities such as long-standing diabetes, where those joints have become stiffened with time, patients will have a lot more difficulty being intubated without difficulty. Our next topic is head position for intubation. Again, there's a short article there that can clarify some things about this topic for you. So the classic teaching is that patients should be in the sniffing position. What the sniffing position is flexion of the lower cervical spine and extension of the upper cervical spine, or at the atlanto-occipital joint. What this does is it protrudes the head and neck anteriorly and lines up the various axes within the oropharynx, the nasopharynx, and at the level of the glottis, it puts those axes in parallel with each other, giving higher success for good views and successful intubation. Our next topic is the insertion of a supraglottic airway device. So it is important to learn how to appropriately insert an LMA because this is part of the difficult airway algorithm. If you're having trouble ventilating, if you can't intubate the patient, the next step is to insert an LMA to help with ventilating while you formulate another plan. So the picture to the right there shows how LMAs should be seated with the various structures involved. The proper way to do this is to either to deflate the cuff or not to deflate the cuff. Different folks have different preferences. My personal preference is to not deflate the cuff, but rather to insert it inflated. You guide the tip of the LMA along the hard palate until you feel resistance. That implies that the tip of the LMA is within the opening of the esophagus and nudging up against the upper esophageal sphincter. The sides then of the LMA will be seated along the piriform fossa on either side, and then the top of the LMA should be just below the base of the tongue. And what this does is it creates a soft seal so that you can introduce air into the trachea. Now, this doesn't isolate the esophagus, so high pressures, high ventilatory pressures can force air down the esophagus and into the stomach, which can insufflate the belly. So there are some contraindications. Obesity is a relative contraindication of an LMA placement. A pregnancy greater than 14 weeks is a contraindication because of the full stomach status. And if you expect ventilation pressures to go above that 20 centimeters of water, you will become more likely to insufflate the belly. So procedures such as laparoscopic surgeries, where you're going to expect higher ventilatory pressures, LMAs should be avoided. All right, rapid sequence intubation is our next topic. So this is actually a slide from the talk that we had the other day with the CA1 class about rapid sequence and in the full stomach lecture. So the purpose is to gain control of the airway as quickly as possible after the patient is sedated, where those upper airway reflexes are taken away. So in order, we need to give a rapidly acting IV anesthetic. Usually this is done with propofol. We use a rapidly acting neuromuscular blocker. Sux is generally the fastest acting neuromuscular blocker, although we can use high-dose rocuronium. That's in a dose of at least 1.2 milligrams per kilogram. We should also apply cricoid pressure, although recently this has been called into question how effective this actually is. It's called the Selleck maneuver, and the image that's sort of in the background there shows what that looks like. Ventilation is generally not necessary. One, because we don't want to insufflate the belly. Two, we have adequately pre-oxygenated the patient, of course. And three, we don't want to take the time to ventilate the patient. The fifth step is you secure the airway. You should hold cricoid pressure until we've inflated the balloon and we've confirmed that end-tidal CO2 is on the monitor. All right, this topic is the incidence of nerve injury. So this data is taken from the closed claims database, which is a group of cases from the Anesthesia Quality Institute that have either gone to trial or been closed, so to speak. So according to this closed claims database, 16% of all claims were related to nerve injury. The most common nerve injured is the ulnar nerve. 20% of these claims were brachial plexus related claims, 16% were lumbosacral nerve root claims, and then 13% were spinal cord related injuries. So if we look more closely at this, ulnar nerve injuries are more common in males than females, and also more common when general anesthesia was employed. This is often due to positioning, where the ulnar nerve going through the ulnar groove has undue pressure placed on it, and then of course because the patient's asleep, they can't recognize that there's this pressure, and they can't move their arm to protect themselves. It is not listed in my slide here, but it's also more common in folks who are more slightly built. There's less adipose tissue protecting those nerves, and so in this case, obesity is protective from most nerve injuries. Our next topic here is osmolarity of IV fluids. So as I'm sure you've noticed early on in your training here, we use a wide variety of IV fluids, both colloid and crystalloid. And two terms to describe IV fluids are osmolarity and osmolality. Now the difference is that when you're talking about osmolarity, that references the number of particles in 1 liter of fluid, whereas osmolality is the number of particles per kilogram. Now, since oftentimes we're talking about water or using substances that are very similar to water, osmolarity and osmolality are nearly interchangeable. But when you start using fluids with different densities, liters suddenly don't equal kilograms. So the other important thing to sort of appreciate from this chart here is that normal saline is not normal. So normal saline is made up of sodium and chloride, 154 of each sodium and chloride, making the osmolarity 308. And you'll notice in the pH column that it's slightly acidemic. The pH is less than that of physiologic pH. If we come down to plasmolite, we can see that it's a bit more isotonic, whereas normal saline is mildly hypertonic, and the pH is much closer to physiologic pH. We most commonly use LR for our crystalloid fluid, and we can see that even though the osmolarity falls into the isotonic range, it's probably mildly hypotonic. The pH is mildly acidemic. The sodium is just slightly less than the standard 140, and it also contains lactate, which is something that we don't necessarily appreciate. So all of these IV fluids are not created equal, and we should be cognizant of what we're giving our patients in addition to just volume. All right, so this topic is transfusion reactions. We could have whole lectures on this entire topic, and whole textbooks have been written. But for purposes of this talk, I've included a short blurb from Open Anesthesia that will help to clear up some of these things. So transfusion reactions can very broadly be broken into immunologic reactions and non-immunologic reactions. So immunologic reactions can include acute hemolytic reactions, delayed hemolytic reactions, febrile reactions, and trolley. What each of these are slightly different in severity and also how the immunology works. So with acute hemolytic reactions, this results in hemolysis of red blood cells, which can lead to anemia, kidney damage, and extremely high potassium. The most common way that this happens is through human error, mislabeling, or other clerical error. Delayed hemolytic reactions are when antibodies exist against the donor non-ABO antigens. These are antigens such as the KID and Kelly, etc. Many of these antibodies also can come from previous transfusion or pregnancy. So when you hear, when you're taking care of a patient and they say, oh, this patient has antibodies, that oftentimes will come from a patient having many previous blood transfusions. Febrile reactions are the most common. These are also often due to cytokines from donor leukocytes, and we can reduce febrile reactions with leukoreduction of products. That means a process that removes white blood cells from the product. Trolley is a situation that's well publicized. It's often donor antibodies versus recipient leukocytes. This results in non-cardiogenic pulmonary edema and can result in the blurring out of both lungs on chest x-ray, not from a heart-related issue. Now, non-immunologic reactions are our next topic here. So these are loosely broken into allergic reactions and TACO, the two most common type of non-immunologic transfusion reactions. As you know, allergic reactions span from just mild itching sorts of reactions all the way to anaphylactic reactions. An argument could be made that this is actually an immunologic type of reaction because anaphylactic reactions are IgE mediated. And most of these reactions will respond to antihistamines. TACO is the most common cause of transfusion-related mortality, and basically this is volume overload after massive resuscitation with blood product. The body, the heart can't handle the extra volume related to transfusion, and pulmonary edema results. So this topic is very commonly tested on the basic exam, abnormal capnography patterns. We have an image over here on the right-hand side of the screen that goes through some of the more commonly tested capnography patterns. So A and B, we've definitely all seen before. A is normal spontaneous breathing, while B is normal mechanical ventilation. C is also a normal pattern. At the end of a case, when we're letting CO2 build up, we reduce the respiratory rate, which increases the amount of expiratory time, and this is simply a one longer cycle. D, we've probably also all seen in the operating room, which represents a patient with some form of obstructive disease. There's this long sort of sloping phase 3 of the capnography tracing. End tidal is represented by the highest number there, the top right of the tracing. Let's see, E represents added dead space. F represents a leak in the sample line. So when the sample line isn't securely fastened to the either the circuit or to the machine, you get a tracing that doesn't quite reach a normal level for most of the tracing, and then there's a little increase in the end tidal right at the end. G represents exhausted CO2 absorbent. You know this because the end tidal never quite reaches zero, and it's sustained. H is sort of a unique one. It's a pattern that we see after a double lung transplant, and the reason for that is that the transplanted lung and the native lung have different compliances, and so you get different fluid dynamics in each of those lungs. I and J and K and L are actually, they're all commonly tested tracings. So I and J represent an inspiratory valve that's stuck open. I is spontaneous, J is mechanical. And in J, we see that the end tidal tracing slopes down slowly until the next respiratory cycle. And it does reach zero, but it takes a while to get down to zero. Now contrast that with K and L, which represents an expiratory valve stuck open, and these tracings never quite reach zero. The reason being that when you expire, expired CO2 goes in not only the expiratory limb, but also through the inspiratory limb. And so the sample line is always sampling some CO2. M is a normal finding. They're called cardiac oscillations. What these are, or what this represents, is that as the heart is beating in the thoracic cavity, it actually moves the lungs and great vessels, and so you can actually see small amounts of air moving in and out of the trachea with each beat of the heart. N is something that you don't often see. It represents electrical interference, could be with very, very long bovying and such. All right, our next topic is attenuation of ultrasound. Understanding of ultrasound is becoming a more and more required topic that the ABA likes to test. And some of the basic science topics of ultrasound are also tested on the basic exam now. So ultrasound physics can get very, very advanced. Just ask the cardiac fellows. But what they would like you to know for basic testing purposes are some of the common measurements of a single wavelength of ultrasound. A single ultrasound wave. So wavelength, of course, is the length of one cycle of ultrasound. Frequency is inversely proportional to wavelength. So as frequency increases, wavelength decreases, and vice versa, because ultrasound travels at a given speed through a given medium, whether it's tissue or fluid, etc. An important teaching point here is high frequency equals short wavelength, and this leads to shallow penetration of ultrasound beam, whereas low frequency equals longer wavelength equals deeper penetration. And you can think about this when you're using the different probes. The curvilinear probe is one with a lower frequency, which emits a longer wavelength, so we use this to image deeper structures, such as structures within the abdomen. The linear probes, which we use for placing IVs and such, emit higher frequency. They have shorter wavelengths, and they have higher resolution at shallow depths, such as where the veins are living. All right, this topic here is degradation of anesthetic gases. It's a little hard to understand what exactly they're getting at with this topic here, but it's a good place to go over metabolism of anesthetic gases. So different gases are metabolized at different rates. So not surprisingly, the gases that we don't use anymore, methoxyfluorine and halothane, were the most highly metabolized. Most of the gases that we use today are eliminated through expiring the gases unchanged. Sevoflurane has the highest rate of metabolism at about 5%. Isoflurane is less than 1% at about 0.2, and desflurane is the least metabolized at 0.02%. Other teaching points, desiccated CO2 absorbent, especially with isoflurane and desflurane being the most common, can cause production of carbon monoxide. And then, of course, we have to think about the environmental impact of our gases. So all anesthetic gases are potent greenhouse gases. That's one of the reasons it's important to use low flows. Desflurane has the largest impact, and they, of course, degrade very, very slowly in the environment. So when these are released through the waste gas scavenging system, these hang out in the environment for a very, very long time and can cause some damage. There are lots of papers written about the environmental impact of anesthetic gases, and if you're interested, you can read more about that elsewhere. All right, our next topic here is epinephrine concentration. So, this is an important topic, as is any math topic, because a small error here can create, tenfold, hundredfold errors that can really, really be dangerous to patients. With epinephrine, the most common concentrations that we use are 1 to 1,000 and 1 to 10,000. Now, the 1 to 1,000 concentration is what comes in that tiny vial. It's code dose epinephrine, 1 gram of medication, and the 1 to 10,000 concentration is 1 gram of medication to 10,000 ml solution. As I said before, the 1 to 1,000 is the little vials are 1 milligram in 1 ml. The 1 to 10,000 are the Bristojet syringes that we get, where you have to give 10 cc's for 1 milligram of epinephrine. Now, when we are mixing local anesthetics, every now and then we'll add epinephrine to locals to increase the duration of action. And the most common concentration that we use is 1 to 200,000. What this represents is 5 micrograms per ml. And if you can remember that, you can basically calculate any other concentration that they would ask you for. All right, our next topic here is context-sensitive half-time, particularly of opioids. That was what was asked on the AKT. So what context-sensitive half-time is the amount of time required for the blood concentration after an infusion to be half, given the duration of the infusion. So for the different opioids on this chart over here to the right, fentanyl has a very, very, very long context-sensitive half-time. It's often used for sedation in the ICUs because, the amount of time that it takes to wear off isn't quite as important as, in the operating rooms when we're under a little bit of time pressure. If we ran, fentanyl infusions for 3, 4, 5 hour spine cases, it would essentially never wear off. You can see after 5 hours, the context-sensitive half-time for fentanyl is upwards of 200 minutes. Now, some of the other fentanyl derivatives have a bit more favorable context-sensitive half-time. So alfentanil is the next lowest. There's a context-sensitive half-time of right around 50 minutes after about 2 hours of infusion. Still a bit on the long side, but not quite so long as fentanyl. Sufentanil is a bit more favorable still. It has a context-sensitive half-time of about 25 to 30 minutes, regardless of duration of infusion after about 2 hours. Now, the reason that we use remifentanil as an infusion is because it has a very, very low and very, very reliable context-sensitive half-time after a short duration of the infusion. So it's about 8 minutes. It's important to remember that patients won't necessarily wake up after 8 minutes. All this represents is that they'll have half the blood concentration after 8 minutes that they had when the infusion was turned off. So after several context-sensitive half-times, 16 minutes, 24 minutes, most of the medication is gone then, and that's when patients will start to wake up. All right, our next here is dexmedetomidine physiologic effects. As we know, dexmedetomidine is an alpha-2 agonist. There is really no direct cardiac action, but there is a reflexive cardiac action related to dexmedetomidine. It comes with a biphasic response, so the first thing that we see is alpha-2 mediated vasoconstriction, and then the bradycardia that we see is a compensatory mechanism. Later, we see mild hypotension, and this is related to the alpha-2 mediated inhibition of the central nervous system sympathetic outflow. So basically, the dexmedetomidine acts on the spinal cord. It reduces the amount of norepinephrine that's released endogenously, and we do see a mild hypotension after that initial vasoconstriction. Some things to sort of note when you're thinking about using Precedex: we really should be cautious when patients have any sort of heart block, as this initial bradycardia can turn into worse arrhythmias. We should be cautious with hypovolemia, as the hypotension can be worsened in the second part of the biphasic response. Patients who are hypotensive to begin with, bradycardic to begin with, we should also be pretty careful with this drug. All right. Our next topic here is LAST. That stands for Local Anesthetic Systemic Toxicity. I included a nice open anesthesia article here about LAST. This is a potentially life-threatening condition related to very, very high levels of circulating local anesthetic that have been absorbed into the systemic circulation. The first thing that we see is central nervous system toxicity. This is the most common thing, although it can progress, which we'll discuss. Classic presentation is perioral numbness, tinnitus, ringing in the ears, feeling dizzy, and just sort of a sense of being unwell. If you progress beyond these initial symptoms, you can have seizure and then ultimately lethargy and coma. If the concentration of systemic of local progresses beyond just neurologic symptoms, you can have cardiovascular toxicity, and this comes from the local actually blocking the conducting system. You see various types of dysrhythmias, conduction delays, and at the very worst, cardiac arrest. Now, treatment of LAST, of course, is to stop any further injection. Our basic ABC approach really comes in handy here. So we need to manage the airway if the patients are unable to protect their airways. We must treat hypoxia, hypercarbia, and acidosis. These conditions tend to make LAST worse. We can also administer benzodiazepines if patients are experiencing seizures. The best way to bind and ultimately eliminate local anesthetic from the system is by lipid emulsion. So this is stored in all of the carts where lots of local anesthetic is administered, namely the block cart and holding. And there are a couple of places at the various anesthetizing locations where we keep lipid emulsion. I know there's one up in PEDS, for instance. It's given in a 1 ml per kilogram bolus initially, and then run in an infusion at 0.25 mLs per kilogram per minute. These numbers are commonly tested, so it's wise to memorize them. Cardiac support may also have to be given, so conventional CPR is the best way to go if a patient's in cardiac arrest. However, we need to give a smaller dose of epinephrine. It's given in 1 microgram per kilogram dose rather than the full 1 milligram every 3 minutes dosing. So there are various risk factors for LAST. Not everybody is at the same risk for this. So it can be loosely broken into patient factors, pharmacologic factors, and then procedural factors. Patient factors include extremes of age, so small children, of course, have smaller weight. They also have less protein in general in which to bind the local anesthetic. Pregnancy puts patients at higher risk for LAST, and then various systemic illness, which causes slower metabolism of local anesthetics. Pharmacologic factors are very important. So drugs that have a very narrow central nervous system to cardiac toxicity ratio, such as bupivacaine, put patients at risk for higher risk of LAST. And then also total dose of local anesthetic, of course, is very important. Ultrasound reduces the risk of LAST, given that we are able to see where vessels are and where we're injecting this local. Peripheral blocks tend to occur, LAST tends to occur greater than neuraxial blocks just because of the sheer volume of local that we're often giving. And of course, block site causes different rates of systemic absorption. So of course, IV is quickest, followed by intercostal, followed by caudal, followed by lumbar, and then brachial plexus, sub-Q areas have lower rates of systemic absorption. There are a lot of good mnemonics to memorize this block site systemic absorption, so find one and pick your favorite.